This meeting is now being recorded.
Well, again, welcome to our EDS Awareness Speakers Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give an overview of our free program for those attending for the first time. So we're going to talk over who we are, what is our program, upcoming events, introduce Dr. Pradeep Chopra, and then we'll have a Q&A after that session. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter Deanna leads this Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was the caregiver for my wife, who struggled with undiagnosed EDS for over 30 years. Tomorrow is the 5th anniversary of her passing, and we dedicate this program to her memory. So we introduced our program in 2012 at the EDS conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 40 groups to date. Each group is given their own free website with a link from the directory and map. In July, we will be a sponsor of the EDS conference for the 3rd time in Houston, Texas. We received feedback from these conferences that they provide valuable information and social opportunities that many cannot afford physically and financially to attend in person. So we decided to bring the speakers to you through the Dr. Speakers Series. We meet every 1st and 3rd Wednesday, typically at 7:30 Eastern Standard Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected for EDSers. The store is the only funding for this program, and it usually covers our monthly expenses. So just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program, and the information is not advice. Always consult your doctor before making any changes to your treatment. Deanna?
Yeah, our upcoming events, we're going to have Dr. Wilson's audio presentation and slides, which are already posted on the site. Those are available. And May is EDS Awareness Month, so please send us details about your local awareness activities so we can also post those on the site. May 7th, we're pleased to have Dr. Stacy Kalish. She's a geneticist from the University of Pennsylvania. She will give us an introduction to cardiac issues in EDS patients and also talk about genetics. So our speaker tonight is Dr. Pradeep Chopra. He is the director of the Interventional Pain Management Center of Rhode Island. Dr. Chopra completed his anesthesia residency from Harvard Medical School and his fellowship in pain management also from Harvard. He's the recipient of many awards, the John Hedley White Award in Critical Care Medicine, the Nancy Oriole Award in Obstetric Anesthesia, prestigious appointment of Assistant Professor, the Department of Medicine at Brown Medical School, and the Division of Biology and Medicine, and Assistant Professor of Anesthesiology, Boston University School of Medicine. Dr. Chopra is board certified by the American Board of Independent Medical Examiners. He's author of several publications on the topic of chronic pain, and he is a member of the editorial board for the Journal of Cancer Pain and Symptom Palliation and Pain Physician. I wanted to remind you that after the presentation, there will be an opportunity for Q&A. You can submit your questions at any time during the presentation by clicking on the Q&A icon located at the top of your screen, and that will open up a box that you can type into, and those will be submitted directly to Dr. Chopra and answered in the order they were received. So welcome, Dr. Chopra. We're looking forward to your presentation. You will see your slides are loading up on the screen now. And you should see those, everybody should see those appear now.
Hello, hi, good evening. My name is Pradeep Chopra, as just Diana just mentioned. So this is really the part 2 of my presentation. We have a lot to talk about today, and in the first part, I had talked about headaches, neck pain, shoulders, wrists, elbows. This one is going to be a slightly different. If we'll talk about neuropathic pain and nerve pain in EDS, we'll talk about some of the joints also, especially the feet and knees. And then I'll be happy to take any questions afterwards. This is the standard disclosure and disclaimer. I have no actual or potential conflict of interest in relation to this presentation or program. I will talk a lot about off-label uses of medications, and the discussions in this presentation are for a general information purposes only. Should discuss with your physician your own particular treatment, and is not meant to take the place of your doctor. So I'll skip over this. Let's talk about feet in EDS. This is a major issue in Ehlers-Danlos syndrome. Because it can affect literally any part of the body. The feet are made up of 26 bones, 30 joints, all small ones, and about 100 muscles, tendons, and ligaments. So within the two little parts of the body, the feet, we have over 30 small joints. And any one of those, if they become painful, can affect the entire body, including your knees, hips, back. So I just wanted to go over the feet today. It was a lot to talk about. It would have been a huge presentation if I just talked about what are the reasons for pain in EDS patients from their feet. So I'll just go straight on to what can be done. One of the things I found interesting was barefoot walking. Barefoot walking is, if you listen to the first set of my presentation, I talked a lot about proprioception, where proprioception means joint sense. And one of the major issues with patients with EDS is that they lose proprioception, or they lose joint sense, which means they don't get as much feedback from their joints and ligaments, and they tend to either hyperextend or hyperpronate or hyperrotate these joints, causing these ligaments to tear or damage ligaments and muscles. Walking barefoot is actually considered to be one of the best therapies for EDS patients, of course, where it's safe and comfortable. It helps with conditioning of muscles under natural loads. Repeated rising on tiptoes, this not only strengthens the muscles in the feet, but also helps with proprioception, which is, again, helps with joint sense, training your feet. The 30 joints you have in your feet, it helps with joint sense and in retraining our joints for joint sense. The heel lift has to be actually lifting up the heel, but not just leaning forward, because you need to move the joints of the heel, of the feet, sorry. When you descend in a very slow, controlled way and not just drop down. Some of the non-weight-bearing exercises are very useful, resistive exercises, especially with bands. Those help too. The best is, of course, a combination of using both weight and without weights. This we just talked about. Proprioception, joint sense is critical to patients with EDS. Standing on tiptoes, raising the heels, and versus leaning forward. Start exercises as a short duration, and then very few repetitions, and then increase over time. Shoes. Fortunately, one of the good things about shoes now is that we have a wider variety of shoes. We have a better understanding on types of shoes that can be. The technology used to make shoes has improved dramatically. The best is to wear what are called trainers or sneakers, as we call them. Those are probably designed the best to support the feet in EDS patients. It helps, wearing the proper shoes helps with unstable ankles, with hypermobile feet. Make sure that the midsole, so the midsole is the part between the heel and the ball of the feet. That portion should be well cushioned. It's important to have a very good and a strong heel counter which provides stability. The fastening, that is the laces for the shoes or the Velcro strips, should be over the midsole of the feet to give you a better support. Some of the newer shoes actually have these fastenings on the side rather than on the top. If you can't find shoes that fit you well, especially in patients with EDS, the next thing to try would be shoe inserts, or what are known as orthosis. Three things you should look for in shoe inserts. One is there should be a very nice heel cup which stabilizes the heel, so it prevents it from rotating inwards or outwards. The shell of the insert should be contoured to the shape of the foot. There should be several different wedges, and some of the new orthotics, you can actually change the wedges to help support the arch of the foot. So these are the three things we need. Heel cup for stabilizing the heel, contoured shell, and it should have wedges, and preferably several types to adjust to joint position. Ankle supports can be used. The only thing you have to be careful about is that they should not restrict movement of the ankle joint. If they restrict movement of the ankle joint, it can lead to knee pain and hip pain at the same time. It's important not to use very soft orthotics because they distort easily, and which is why kind of hard, not very hard, but kind of hard orthotics make the best sense for EDS. Knees in EDS patients. The two things that cause, there are many things that can cause problems in knees. One of them is poor proprioception, which again, as I said, was poor joint sense. And if there's any one joint in the human body that needs proprioception the most, is actually the knee, and then it's the feet. Poor proprioception in the knee joints and the proximal interphalangeal joint, what is also known as the PIP joint, that, as you can see, is a joint. It's in the midfoot. So these are the proximal interphalangeal joints. Poor joint sense of these joints as well as the knee joint can cause knee pain in patients with EDS. Hyperextension is one of the major issues in EDS. So the normal knee will hyperextend a little bit. That's the locking position. So when we stand, our knees, you can flex your knees and then you can extend your knees. As you extend your knees, we use extension while walking, but when we stand, we tend to hyperextend our knees, which is the locked position for the knee. The problem in EDS is that we tend to hyperextend our knees. And the reason we hyperextend our knees is because we don't have joint sense. We don't realize we're hyperextending our knees. What happens is when you hyperextend your knee, there is a small pad of fat. I'll show you. This is a section, this is really not a clear picture, but this is a section of the knee joint. And if you can see this yellow portion right below the patella, there's a pad of fat right there. It's this pad of fat that actually gets pinched between the patella and the knee joint. So if you hyperextend your knee, if you hyperextend this knee, this pad of fat gets pinched between this patella and this bone. And that's one of the reasons why why patients with EDS will have pain. The other reason to have pain is the ligaments inside the knee joint. So there are some ligaments inside the knee joint. They're called the anterior and the posterior cruciate ligaments. Those ligaments are damaged and they can cause pain. So the trick here is to avoid hyperextending the knee. And that's the hard part, because we don't realize when we walk or when we stand, we are hyperextending our knees. So try to keep the knee in a mid-range position, which means between extension and slight hyperextension, but not over hyperextending the knee. One other trick to do is to use a compression knee sleeve. And John, how do you use the cursor over here? How do you use the arrow on this thing?
If you click on the Show Presenter's cursor in the upper right-hand corner under Options.
Got it.
There you got it.
Got it.
Great. Okay.
So keeping the knee to avoid. So here's the hard part about hyperextending the knees in EDS. The problem is that as we walk, we don't really realize how much of our knees are we hyperextending. Normally we do not hyperextend our knees when we walk. We flex our knees, we extend our knees, but we don't hyperextend our knees. The only time we hyperextend our knees is only when we are standing. When you stand, you lock your knees, and the lock position is a hyperextended position. So for EDS patients, I usually recommend that when they're standing, they should be cautious about how much of a hyperextension of their knee they're doing and to avoid it. Best thing is to keep it in the mid-range position. Compression knee sleeves work well also. Compression knee sleeves, we had talked about using compression sleeves for different joints. And compression knee sleeves, one of the things they do is, not as much as, they don't really compress anything all that much, but it helps with joint sense or helps with proprioception. So I think it's a great idea to use a compression knee sleeve to have a better idea of how much you're hyperextending or flexing your knee. We talked about the anatomy. The patella is this small bone here. It's the floating bone in front of the knee. It is held in place by a ton of muscles and ligaments. There are muscles and ligaments that connect to the patella all over it. And the patella, the reason it's connected to so many muscles is to keep it in a fine balance. The problem that happens in EDS is that this muscle balance is shifted. And when it shifts, it actually affects the hips, the pelvis, and abnormal gait. Any of these can cause the patella to shift. And when the patella shifts, it pulls on the muscle, it pulls on the ligaments, and that causes pain. So what I'm trying to point out is that knee pain can come from problems with the hip, problems with the pelvis, and having an abnormal gait, which means, again, problems with your feet can cause pain around the knee. That is the patella. This is the frontal view, so you can see the patella from the front. This is a ligament that connects it in the front on the top. This is the ligament that connects at the bottom. There's a bunch of muscles called the quadriceps. They connect them here. There are some more muscles on the side that connect to this patella. They're not shown in this picture here. So to deal with knee problems from the patella is to have a physical therapy program or a rehab program that actually addresses the imbalances in the muscles around the patella, the knees, and the pelvis. So we can't just say, all right, this is a knee problem, and we look at the knee only, because you have to look at the pelvis, you have to look at the hips also. Especially these two muscles, the quadriceps group of muscles, and something called, commonly known as the IT band, also known as the tensor fascia lata. It's the muscle, if you put your hand on the side of your thigh, there's a longish muscle that goes down, and it's called the IT band. It's very well known. And then the other one is the quadriceps. I'll show you the quadriceps. This is the quadriceps muscle on the front. The IT band is on the side, on the outer side of the patella, of the thigh, sorry. Manual techniques to relax and lengthen the IT band and the vastus medialis obliquus muscle. I'm sorry, that's a long name. I didn't name it. It's a muscle that's in front of the thigh, and it's responsible for some of the movements of the knee joint. So techniques that will actually relax and lengthen the IT band and the vastus medialis. Most patients who complain of pain from the knee almost always have a tight IT band, almost all of the time. And of course, the other technique is to use patellar taping, which is physical therapy tape that they use. So I went over briefly over the feet and the knees, but before I move forward, I just want to stress how important it is to manage pain from the feet. I believe that if you have pain in the foot, it has to be addressed right away, because that can lead to knee pain, hip pain, back pain, even upper back pain. Pain in Ehlers-Danlos syndrome can be from actually four things: from the nerves, what we call as neuropathic pain; from muscles, what we call as myofascial pain; and from joints, what is known as nociceptive pain; and the fourth one is headaches. On my last presentation, I had gone over headaches and myofascial pain, nociceptive pain. We'll go through neuropathic pain and nociceptive pain on this presentation. Nerve pain, also known as neuropathic pain. We don't know why patients with Ehlers-Danlos syndrome develop nerve pain. We're not quite sure. There are a few theories behind this. One is that, the nerve connective tissue, is it more fragile in Ehlers-Danlos patients? That's one of the theories. We don't know for sure. The other thing is, are these fragile nerves, do they get overstretched when they cross a hypermobile joint? So, for example, if you have a nerve that crosses your knee joint or a nerve that crosses your shoulder joint, is it getting overstretched and damaged every time we use that joint? And the third theory is that patients often develop what is called a small fiber neuropathy. Small fiber neuropathy, briefly, if you look at the nervous system for the human body, it's like the roots of a tree. And as you go further away from the root of the tree, the main root, the roots become finer and thinner and thinner, and finally they become really as thin as a hair strand. And that's exactly what happens. As the nerves come out from the spinal cord, they are thick. And then as we go further down to our feet, by the time they reach the toes, they become really, really small. And that's why they're called small fibers. A lot of the patients with Ehlers-Danlos, a lot of the Ehlers-Danlos patients develop small fiber neuropathy. But there are patients without Ehlers-Danlos syndrome also who develop small fiber neuropathy. We're not quite sure why EDS patients develop small fiber neuropathy. It's fairly common. I don't know if it's got anything to do with connective tissue, if there's something else going on. One of the other theories about small fiber neuropathy is there an autoimmune condition associated with EDS? The thinking now is that we're now thinking that more and more patients with EDS have an autoimmune condition, which then results in small fiber neuropathy. One of the more severe neuropathic pain conditions is called complex regional pain syndrome, or CRPS, or RSD. We'll get into a lot more detail with that. This is a slide I wanted to touch on real briefly, especially in children. Mitochondrial disease. We do see a lot of mitochondrial diseases or disorders in kids with Ehlers-Danlos syndrome or nerve pain. Briefly, mitochondria are little structures in the human body that produce energy. They are in each cell. Each and every cell has something called mitochondria, and the sole purpose of these mitochondria is to produce energy. For whatever reason, for genetic reasons, hereditary conditions, for whatever reason, these mitochondria are not functioning at best, and so they're not producing enough energy. The nerve cells in our body use up the most amount of energy. So as a result, in patients with mitochondrial disorder, nerves are the first ones to be affected. Patients often present with widespread pain, especially nerve pain. They have exercise intolerance, muscle weakness, seizures, developmental delays. It's hard to say because a lot of the patients with other conditions have the same symptoms, muscle weakness, exercise intolerance. This is something that a mitochondrial specialist would have to look at. Most pediatric hospitals do have a department. They're called metabolic centers, or mitochondrial centers. If you go online, you'll find it. It's something that should be ruled out, especially in children. If they have kids presenting with symptoms of exercise intolerance, it's almost like they start off with full blast energy and then they run out very quickly. They have muscle weakness, they have seizures, but it's often not seen in adults. I worry about adults who have mitochondrial disorder but were missed as children. We don't know that, but it's something to keep in mind. Let's talk about complex regional pain syndrome for a minute. This is a common nerve pain that we see in EDS. Again, we're not quite sure what the relationship is, but it's a common condition that we see, especially in kids who present with severe nerve pain or CRPS. It mostly turns out to be they have either EDS or mitochondrial dysfunction or both. This is a condition that is characterized by continuing pain that is disproportionate to the usual course of any trauma or lesion. So oftentimes patients will present with a small trauma, minor trauma like a foot sprain, but the pain is unimaginable. It's far more than that would be expected. It usually starts after a trauma. Now it could be a surgical trauma also, or it could be a trauma that you have after, say, you fell down or you sprained your foot. It can happen with even a minor trauma like getting a blood draw or a nerve block or just tripping over and falling down. Rarely do we see this in patients after a stroke. So briefly, the human nervous system is a very well-designed array of nerves. This is a very complex system. Nerves relay messages to and from the brain, which controls all the functions of the human body. The beauty of this is that the nervous system can control its own pain. It can modulate any strong signals to protect the human body. So we have our own system. So if you have a, say if you stick a pin in your finger, the amount of pain that travels up into your arm and into your brain, the brain automatically modulates those signals. It turns down, it's almost like turning down the volume of these pain signals. So the nervous system has a built-in mechanism to protect us from severe pain. This is what happens in CRPS, or actually this is what happens in most neuropathic pain, is where it's the nerves themselves that become painful. Now, under normal circumstances, nerves are just messengers. They are electrical wires that carry the signal. They are messengers. This neuropathic pain, especially in complex regional pain syndrome, the nerves themselves become painful. The risk factor is trauma. It can be from immobilizing. So somebody has a fracture, which is common in EDS patients. So you have a fracture of the arm, and they put you in a cast, and despite having your arm in a cast, you still continue to have severe pain. Suspect CRPS right away. You should not have pain if your arm is in a cast or if your leg is in a cast. There should be no pain. Patients with history of migraines and asthma are more prone to neuropathic pain. It's more common in women, and we're not quite sure about the genetic correlationship. The McGill Pain Scale. So the University of the McGill University in Canada came up with a classification for severity of pain. So if you look at the scale, non-terminal cancer pain is about a little higher than 20. Labor pain is about 35. Amputation, if you cut off your limb, the pain is around 40. RSD is higher than that. So it's actually the most painful condition in the human body. So the pain is far more than what would expect from the type of injury. So anytime you have an injury and the pain seems to be much more than what you would expect, suspect CRPS. It also lasts a lot longer. One of the classical symptoms of nerve pain is pain to touch, also called allodynia. It's just soft touch. It's not a painful touch. So if you softly touch that part of the body, if it's painful, it's called allodynia. It may actually spread like a ripple. So if I touched, say if I had RSD or CRPS of my thigh, and if I just touched it over the front of my thigh, the pain would spread out like a ripple. Oftentimes, patients always complain of it being a creepy, crawly sensation, sharp razor blade-like or tingling sensation. Color change, there is definitely a color change. It can go from anywhere from red to dark blue to pale. The only exception is that if someone has CRPS to both sides, so you won't see the color difference. This is one place I need to point out. In Ehlers-Danlos syndrome, patients do have color change, and that's not because of it may not be because of CRPS. We'll talk about why patients in CRPS have color change in a few slides. But this is CRPS. In CRPS, one of the classical symptoms is there's a differential color change. So the limb that has been affected may have a dark blue color to a red color to a pale color. It can happen for no reason on its own. Oh, here we are. So oftentimes EDS patients will have color change to their fingers and toes, usually becomes dark purple. It may not be because of CRPS or Raynaud's phenomenon. What happens is that the veins in the limbs have weak connective tissue, and so blood tends to pool in the limbs, and so when it pools over there, it becomes dark purple in color, and that's an EDS feature. It's not a CRPS feature. The major difference is that in CRPS, it is usually in the affected side. In EDS, it is on both sides. So this is a picture of CRPS. So as you can see, this lady has the color. You can see the color change on the right hand compared to the left side. You can see that. You can see some swelling. The right hand is definitely swollen. You can see it at the wrist, how it's swollen. This is again, you can see some color change. The left foot is darker than the right foot. They also have nail changes, nail growth changes, and you can see how this nail is distorted, is ridged, is discolored. Well, they're both discolored, but this one is distorted also. Temperature change. CRPS in patients with neuropathic pain. Again, neuropathic pain, CRPS, they can present with temperature difference. The limb that is affected is either colder or warmer. It is usually colder. The official definition is that if there's a 1 degree difference, that's considered to be significant. The only exception is that if the CRPS affects both limbs, then you're not going to see a temperature difference. Or if the CRPS is on the chest or the abdomen or back, then you won't see this. Temperature must be checked with a thermometer, with a laser thermometer, not with the back of the hand. This is when you go to a physician or a healthcare provider, make sure that the temperature is actually checked, because a 1 degree difference you may not make out by just touching with the back of your hand. Temperature differential is really important. Now, again, in EDS, you may see EDS patients often have what is called temperature instability. So they go from hot to cold, cold to hot very quickly, but the temperature changes in both limbs at the same time. In CRPS, it is only the affected side. Swelling is usually in the early stages. It comes and goes. There's no rhyme or reason. It has nothing to do with how you're active or non-active. It can happen on either side or it can happen on both sides. Oh, I'm sorry. This is, again, I wanted to show you the swelling. There's increased sweating. It's called hyperhidrosis. Patients will complain of a lot of sweating. It can happen even not on the affected side. It has nothing to do with the room temperature. You can be sweating in the middle of winter. Muscle spasms are very common in CRPS and in neuropathic pain patients. They can be weakness, they can be tremor, or they can be dystonias. Dystonias are like muscle spasms, except they're far more severe. Here's where you can see some dystonia in this gentleman's hand. You can see how his finger has flexed. It's actually fixed in this position. You can see the pinky is flexed. The ring finger is almost flexed. Same patient. You can see it on both sides. This has gone a little beyond dystonia. I showed you the nail changes. The nails may grow faster. They may be distorted. Hair growth. Hair can grow faster. It can be darker. It can be coarser. Or it can be just the opposite. It can start to fall. There are skin lesions. The skin becomes thinner. You can see some skin lesions. I wanted to show you the nail changes here. You can see some nail changes over here in this foot. I can't show you, but of course these nails are growing much faster. This is actually a 1 week growth on this lady. And they're distorted, you can see that. This again, I wanted to show you skin lesions. She has a skin lesion over here. There are all kinds of skin lesions that show up in CRPS. She has swelling. You can see the marks, the socks she was wearing. Of course, there's a color change here. The nail on this foot, you can see that it's growing, it's distorted. This one actually fell off, and it's distorted. These are the classical symptoms of CRPS. So you have pain to touch or negative sensations to touch. You have swelling, nail and hair growth changes, swelling. So the diagnosis of CRPS is usually made one of the criteria is that it cannot be explained by any other medical condition. Now, this is official diagnosis. I don't quite agree with that. It's just I would word it differently. I would say it's a medical condition that we don't know yet, but there is a medical condition that causes CRPS. Now, how does EDS cause CRPS? We don't know that. The pain is much more severe than expected. There's pain to touch, swelling, skin and hair changes, temperature changes, muscle spasms. The only way to diagnose CRPS is by a good history and physical examination. There's really no blood test or test that can be done. I often recommend a repeat examination because some of these changes may not happen when you're in the doctor's office. For example, color change or temperature difference may not happen while you're there. So I usually like to, do a repeat examination to make a definitive diagnosis. If you do have a color change or especially color change or swelling, it's good to take pictures comparing both sides. Take them with you when you go to see your doctor. These are a list of tests that patients often have to undergo for a diagnosis of RSD. None of them are useful. X-rays, MRIs, bone scans, bone density, blood tests, skin biopsy, sympathetic nerve tests, sweat tests, which is called as a QSAT, sympathetic skin response, EMGs. None of these tests are useful for diagnosing RSD, none of them. The only reason you may want to have a test, one of these tests, is to rule out any other diagnosis. Skin biopsy is only done for small fiber neuropathies, but other tests are totally useless. Management. Now, even though it's management of CRPS, you can extrapolate this to management of most neuropathic pain conditions. There are a bunch of drugs that can be used for treatment of neuropathic pain. Anti-seizure medicines, antidepressants, a group of drugs called NMDA blockers, and then there are a few miscellaneous ones. So what I did was I did my own little classification, and I've color-coded the treatments that are out there. So green, I've marked them as green if I feel that they're helpful. Yellow may be helpful, and I would avoid the ones that are in red. Gabapentin and pregabalin, also known as Neurontin and Lyrica. It may help. It's usually these are the two drugs that most physicians will start their patients on when they come in with nerve pain. There's no harm in trying them. They have been known to help patients. Gabapentin is a slow-acting drug. It takes forever to work. Usually, you start to notice a difference, if any, after about 3 or 4 weeks of being on it. And sometimes the difference is so small or slow. It's so small that you don't even notice it until you come off it again. Pregabalin, also marketed as Lyrica, Lyrica. It is similar to gabapentin, but it's a much faster-acting drug. So you get to know whether it's working or not sooner. My rule of thumb is that to try any drug for 8 weeks. And if in 8 weeks you don't see a difference, then taper it off. Antidepressants, there are a ton of antidepressants in the market, but there are only a few that actually work for pain. One of them is called the tricyclic antidepressants. This is an old group of drugs. They have been well studied in nerve pain, not specifically for CRPS. The three drugs in this group I like are amitriptyline, nortriptyline, and imipramine. They do work well. They've been used for a long time. Very low doses, not in very high doses. They do make you very sleepy, worth trying them at night. Again, try it for 8 weeks if they make a difference. Amitriptyline and nortriptyline are the two most popular drugs that physicians like to try. There is another group of antidepressants called the SNRI, commonly known as Prozac or Zoloft. They do not work well for chronic pain. They don't have any value. So usually my argument on that is, if you are going to be on an antidepressant, why not take one that will work for pain also at the same time? But this would be it. So looking back, if somebody were to had neuropathic pain, it would be a good idea to start on either gabapentin or pregabalin, and then add an antidepressant, a low-dose antidepressant from the tricyclic antidepressant groups like the amitriptyline or the nortriptyline. This is another group of drugs for depression. They are called SNRIs, or also known as selective norepinephrine release inhibitors, which in English means that they increase norepinephrine levels in the nervous system. There are two drugs commonly marketed. One is called milnacipran, and the other one is called duloxetine. In the U.S., milnacipran is Savella, and duloxetine is Cymbalta. Between the two, these two drugs are considered to be antidepressants. And the way they work is, among other things, the way they work is they increase the norepinephrine level in the central nervous system, which helps modulate pain. Of the two drugs, I feel milnacipran is a better drug to control nerve pain because it increases norepinephrine levels by 3 times as compared to duloxetine. So if you're going to be on one of these, it's better to be on milnacipran, which increases norepinephrine levels much more than duloxetine does. The thing to watch out for is it may increase blood pressure and heart rate. So, but it's not that significant. It's worth it. So we just talked about. So this is how I would go. Start with gabapentin or pregabalin. Add a low dose of amitriptyline or nortriptyline or decimapramine, and then if I don't want to add a tricyclic or an antidepressant, I might even add milnacipran to the gabapentin and the Lyrica. So what I'm trying to say is low doses of each of these drugs may all add up together. The third group of drugs is called NMDA receptor blockers, or N-methyl-D aspartate receptor blockers. There are actually a bunch of drugs, but the 3 that I like to discuss are ketamine, dextromethorphan, and memantine. Dextromethorphan is marketed as Delsin in the U.S. It's a common ingredient for cough syrup. It has been shown to be effective in diabetic peripheral neuropathy. It hasn't been studied in CRPS or postherpetic neuralgia. Personally, I don't like dextromethorphan a lot because it really doesn't help. I've tried it. It's a very weak NMDA receptor blocker. The drug that I would prefer as an NMDA receptor blocker would be ketamine. So let's talk about ketamine. So what are NMDA receptors? What happens in neuropathic pain or nerve pain is that nerve pain doesn't respond well to conventional painkillers like narcotics, morphine, or like the Motrins, ibuprofen, or even drugs like acetaminophen or paracetamol. What we've seen is in patients with nerve pain or CRPS, there's an activation of the NMDA receptors. So it makes sense to use an NMDA receptor blocker to help control nerve pain. Ketamine is an old drug. It's been around for 30, 40 years. It's used in the operating room and in emergencies. It's one of the safest anesthetic drugs. It's a very strong painkiller. The problem with that is that it's not absorbed well when you take it as a pill. It is very effective when given as a low dose intravenously or even as a sublingual, which is under the tongue. It does work better. Ketamine is again, it's not a permanent solution. I gave it a green ranking over here. It's not a permanent solution, but for the time being, it helps control neuropathic pain, especially CRPS pain, very well, especially when used in low doses. This is a drug that I like a lot for treating not just neuropathic pain, CRPS, even for EDS. Naltrexone. Naltrexone is an old drug. It was developed about 30 years ago to treat addiction, especially addiction from heroin and alcohol. But what we did find that when you take it in a very small dose, in a very tiny dose, it can help with some of these more severe nerve pain conditions. There are many theories as to how LDN or low-dose naltrexone works for nerve pain. One of them is that it reduces the production of certain chemicals that cause nerve inflammation. The other theory is that it may increase production of endorphin in the body. Endorphin, as you know, is morphine that is produced by the human body. So it sort of uses that method. The other theory is that it increases the number of opiate receptors. So there are receptors on which morphine works. So it increases the number of morphine receptors in the body, thus making it more effective for the endorphins. The dose for LDN or low-dose naltrexone varies anywhere from 1.75 milligrams to 4.5 milligrams. It's always a good idea to start it at a lower dose and then go up on it. I don't usually stick to the rule of 4.5 milligrams. I have a few patients where I've seen better results at 6 milligrams or even 8 milligrams. One of the side effects, the side effects are very minimal and they're very transient. You just see them in the beginning and then afterwards you don't really see them. One of them is insomnia, which is why I recommend taking it in the morning. They do cause headaches. Again, those headaches go away after some time. Most patients will report increased physical activity. The flare-ups are not as often and they're not as bad, and they have better tolerance to pain. The thing to be careful about is that we can't take any opioids or tramadol when you're on it because it blocks the effect of opioids and tramadol. So how does LDN work in EDS? I'm not sure. I was using LDN. I've been using LDN for a few years now to treat neuropathic pain and CRPS. And then I had patients who had EDS come in with CRPS, so I was giving them LDN for treating their neuropathic pain or CRPS. And a lot of them came back and they said that seems like it improves their symptoms of EDS also, not just the pain. So it helps with the fatigue, it helps with their sleep, it helps them be more active. No one has really studied the use of LDN in EDS patients. There have been no studies done so far. So I've been using it for some of my Ehlers-Danlos syndrome patients. They all have pain. So I use it for both the pain part of it as well as the EDS component of it. It's a very cheap drug. You can buy it. It has to be compounded by a pharmacy. The smallest pill that you can get as a prescription is 50 milligrams. So you have to sort of have the compounding pharmacy make it up, and they can bring it down to 4.5 milligrams or even 2 milligrams. Again, my rule of thumb is that try it for 8 weeks. If you notice a difference in 8 weeks, stay on it. If not, then you have two options. One is to either increase the dose, or the second option is to, then stop it. Free radical scavengers. For free radical scavengers are, so this is an important group of drugs that they're also known as antioxidants. So the human body is made up of molecules, and when a molecule is made up of positive charges and negative charges, and each molecule is in balance. So if a molecule has 5 positive charges, it has 5 negative charges also. For whatever reason, what happens is some of these molecules will lose one of their electrons, and it becomes unstable. So now the molecule has only 5 positive charges and 4 negative charges, and it becomes unstable. When it becomes unstable, it's called a free radical. A free radical is a hungry radical. It looks for another electron, and it steals it from healthy tissue. And when it steals it from healthy tissue, it damages the healthy tissue. So the trick is that if I can take a drug or by some mechanism remove these free radicals or supply my body with a lot of negative charges, I could actually neutralize all these free radicals. One of them is, this is a list of some of the antioxidants or free radical scavengers. Alpha-lipoic acid, vitamin C, DMSO, also known as dimethyl sulfoxide, N-acetylcysteine, and something called earthing. I'll go through each one of these. I can't go through earthing at this point. It's a long conversation. But if you do Google earthing, there's a nice little book you can get on it. It's phenomenal, and it's worth trying it. The book really explains very well how earthing works for as a free radical scavenger. DMSO is not a pill. It is only for topical use. You can actually buy it over the counter, 50% DMSO. I gave it a green because I think it's a great drug to try. It's particularly useful for warm CRPS, where patients' limbs are still warm. It's worth trying it. You apply it 5 times a day topically. And if you have cold CRPS, then you can try it, but not more than a month. DMSO 50%, you don't need a prescription for it. There are some compounds that you can buy that are now marketed which contain DMSO in addition to other drugs. We'll talk about that. N-acetylcysteine, again, it is a free radical scavenger. It's a non-prescription drug. You can get it over the counter. It's a great drug for especially patients who have cold limbs or cold pain. 600 milligrams 3 times a day for 3 months should give you an idea how well it works. It does cause some gastric irritation, so take it after food. Vitamin C. Vitamin C is a free radical scavenger. It does work well, may be helpful, worth trying it. There have been a couple of studies that have shown that vitamin C helps in prevention of nerve pain or CRPS. I am not quite sure how it works in patients who already have CRPS or neuropathic pain, but it's worth a try. The dose is usually 500 milligrams a day. I would certainly recommend it if somebody had or was prone to nerve pain or was at risk of having nerve pain, to take vitamin C for approximately 45 to 50 days. alpha lipoic acid is again, it's over the counter. There's a very nice book you can read on this drug. It's a phenomenal drug. It's a very strong free radical scavenger. There have been great studies done in use with diabetic neuropathy and all types of neuropathies. No trials done in CRPS. It has been approved in Germany and actually in most of Europe. It's used for neuropathic pain. You can buy this, again, you don't need a prescription. It's, the dose is 600 milligrams to 1200 milligrams a day. Oh, here it is. It can be taken 600 milligrams to 1200 milligrams a day. It works very well when taken IV, but it's literally impossible to get it as an IV, but you can take it as a pill also. Very useful in CRPS, useful with patients with POTS and dysautonomia where they have autonomic neuropathy. Now, I've given this a yellow because there are no great studies on it, but it's, in my practical experience, I think it works well, so it may be helpful to try it. No harm done in trying it, again, for 8 weeks. Calcium regulating drugs, these are drugs that are used commonly to treat drugs like osteopenia, osteoporosis. The drugs, they're often marketed as pamidronate, clodronate, alendronate. There's a new drug, it's still not marketed, it's under research called neridronate. It does help patients with nerve pain, CRPS. It does help them. There have been good studies to show that. It's also helpful in patients with EDS because most patients with EDS have osteopenia, but they also have mast cell activation disorder. We'll talk about mast cell activation disorder later. It does help with that. Alendronate is the only one that comes as IV and as a pill. But the pamidronate is only IV. I believe it's available in most countries now. Muscle relaxants, I gave it a red because I don't think muscle relaxants are all that great for pain. They do help somewhat. They do make you sleepy, so they're great for patients who don't sleep well. The way muscle relaxants do nothing for muscle spasms. They decrease muscle tone, and that is how they work. There's no harm in trying it. There are 2 drugs that are approved for long-term use. One of them is called baclofen, and the other one is tizanidine. Most muscle relaxants make you really sleepy, so if you have sore muscles, tired muscles at night, it's definitely worth trying them. But they're not going to help much with severe chronic pain. The other ones is the cyclobenzaprine is marketed as Flexeril. There are other drugs which are not true muscle relaxants like diazepam group of drugs, clonazepam. They may have some benefit, marketed as Valium. Magnesium, I gave it a yellow. It may be helpful. Magnesium is an important important element for muscle functioning, bone functioning, and nerve functioning. There are no good ways to test magnesium levels in the blood because magnesium lives in bone and muscles. You can buy magnesium over the counter. There have been studies that have shown magnesium to help with a lot of conditions, headaches, migraines, nerve pain. The one that I recommend most is called chelated magnesium. Chelated magnesium means that they took a magnesium molecule and they combined it with a protein molecule. So the human body will then absorb chelated magnesium much better than it would for other magnesiums like magnesium oxide or magnesium chloride. If you go to your the local fancy pharmacy, the ones that stock a lot of the vitamin stuff, you'll find it chelated magnesium. It's pretty popular. You can even buy it online. Acetaminophen, also known as paracetamol, It's not a great drug for nerve pain, but it's a good drug for nociceptive pain, which is what I call as joint pain or muscle pain. It is one of the safest analgesics you can take. It's good for mild to moderate pain, best taken before the pain gets worse. It also works very well when it's combined with non-steroidal and anti-inflammatory drugs like naproxen, ibuprofen, or even with opioids like codeine and oxycodone. The beauty of this drug is that if you combine it, so if you took one acetaminophen or paracetamol and you took one ibuprofen, if you combine the two, it's 1 plus 1 is actually 4. It actually potentiates the effect of both drugs taken separately. Just keep an eye on the maximum dose. The maximum dose is now 3,000. It's 3,000 milligrams. I'm sorry. It should be the maximum dose is now 3,000 milligrams, which roughly is about 9 regular Tylenols. Non-steroidal anti-inflammatory drugs are naproxen, ibuprofen. They're good, very good drugs for controlling pain. The only problem is that they have pretty nasty side effects, gastric irritation, they affect kidneys, they affect blood pressure. It's not something that I like to use a lot. They're good for short-term use, but not for long-term use. They do work well when they're used as in a topical formulation. So as an ointment or as a gel, they work really well. Can be used. I would recommend that for joint pain and muscle pain, but not for treating neuropathic pain. So patients with EDS have both. They have nerve pain, they have muscle pain, they have joint pain. So if you can take like ibuprofen or naproxen along with the other pains, it'll at least help with the joint and muscle pain. Topicals these are one of my favorite group of drugs. Again, the NSAIDs, like I said, are very effective and used topically. Say, for example, if you have knee pain or wrist pain, using a topical NSAID there would make a lot of sense. You can actually there's a prescription drug that combines DMSO with diclofenic acid. So it works both on nerve pain as well as joint pain. Topicals avoid the side effect of oral medications. And if you can always ask compounding pharmacies can always cook up some of these topicals. You can have your physicians, order it from the compounding pharmacy, say a mixture of ibuprofen or one of the NSAIDs like diclofenic acid combined with other drugs that you can use. For example, you can use diclofenic acid, which is a non-steroidal anti-inflammatory, combine it with DMSO. DMSO is officially not approved for treating pain in human beings. It's actually approved as a penetrating agent. DMSO helps penetrate skin very well. So what they do is they take DMSO, they take diclofenic acid, combine it with DMSO, so the DMSO carries the diclofenic acid into the joint. But the beauty is that DMSO itself also works on pain. Those of you who have worked with horses would know that they use DMSO a lot in joint pain in horses. In the U.S., it's marketed as Pensaid. Some of the active additives that can be used in compounding lotions and creams is DMSO and something called Active Max. The thing to be careful about is when ordering from a compounding pharmacy is to make sure that they are mixed with other additives that actually will help the drug penetrate through the skin. There's no point in using a lotion if it doesn't go through the skin and into the muscle or the joint. So it's important to make sure that the compounding pharmacy actually uses an additive that will help the active drug penetrate through the skin and into the joint. There is something called Flector patch available in the U.S. It's actually a diclofenic acid. It may be helpful for especially joint pain and muscle pain. Lidocaine patches are not that helpful. They're fairly expensive and they haven't been really shown to work well in nerve pain. Opioids or narcotics. The problem with opioids is that they can be counterproductive in chronic pain. They're good when taken in mild doses for short term for treating acute pain, but when taken over a long period of time, and especially in higher doses, it can actually sensitize patients to nerve pain. This is the problem. Again, for short-term use, they're great. They're actually safer than using non-steroidal anti-inflammatory drugs like ibuprofen or naproxen because it doesn't affect the stomach or the kidneys or the blood pressure as much. Combined, but again, opioids combined with acetaminophen or paracetamol works much better and keeps the dose lower also. I know everyone worries about addiction and opioids. I just wanted to point out something interesting. If this green egg were to represent the total pain population on narcotics, this little red egg would be the number of patients who would actually get addicted to narcotics. So as you can see, addiction in the pain population on narcotics is only 2% to 5%. So about 98 to 95% of the patients do not get addicted to narcotics. But I just wanted to show this to you because I want to reassure you that addiction is not the main issue here. The main issue is that opioids actually sensitize patients to nerve pain. Patients with nerve pain, when they take opioids, it makes them more sensitive to pain. This is an option that I usually recommend patients, especially EDS patients, is to go on a gluten-free diet. Most of you know this by now. Gluten is a protein that's found in wheat, rye, barley, and other grains. The body looks at gluten as a foreign protein, and it causes an inflammation in the human body. And that inflammation affects the nerves, which causes more pain. It can cause migraines, chronic body ache, fatigue, abdominal pain, fibromyalgia. It can worsen hypermobility syndromes. I don't know, testing for gluten sensitivity is not that sure. The best and the easiest thing is to hold off on gluten foods for about 8 weeks and see if it makes a difference. Most patients usually will notice a difference within a week or two, but try it for 8 weeks. All treatments, whether they are medicines or exercises, start low, go slow. Always start at a low dose and proceed or progress very slowly, whether you're exercising, whether you're doing repetitive exercises, whether you're doing weights. Again, start low and then proceed, move forward very slowly. Same thing with medicines. Start at a low dose and then go up from it. Especially in patients with EDS, this is even more important because a lot of the patients have what is called mast cell activation disorder. More about that later. Questionable treatments for nerve pain. All of these are red. Electrical stimulation. Any treatment, there are lots of treatments out there that people plug in. They put electrical pads onto you and then they zap you with currents of different kinds. And none of these are really regulated by any of the agencies. We have seen a lot of issues with these cases, especially in EDS. We are seeing a lot of them. I would avoid any electrical stimulation with any of these devices. The only one that I would, if you want to try it, is the TENS unit. It stands for TENS. That's been around for a long time. It's a very low voltage. That would be the only one that I would suggest trying. But anything else that involves higher amounts of electricity, stay away from them. Psychiatric treatment. EDS is a real condition. It's not in your head. It's not made up. You're not faking it. It's a real condition. You know it. Oftentimes, patients with EDS, because of the number of symptoms they have, from fainting to heart racing to multiple joint pains, fatigue, they're often branded as making it up, and they're often referred to for psychiatric treatment. If you come across a physician who does suggest that, I would stay away. I would stay away from them. Yes, patients with chronic pain can have mental issues such as depression and anxiety, but that's not what I'm talking over here. What I'm trying to say is that if you know EDS, if you know you have EDS, it's a real condition. We talked about, stay away from opioids. Nerve blocks, bad idea. Trust me, I'm a pain medicine specialist. I do nerve blocks all the time, but I would not do it in a patient with neuropathic pain, CRPS, or EDS even. I try not to do them. Stay away from, this is sympathetic nerve blocks, but in EDS I would stay away from any kind of nerve blocks until and unless you're really sure that it's going to make a difference. In EDS patients, they do have joint pain, and I would be very cautious about doing nerve blocks in patients with EDS. Spinal cord stimulators, this is basically an electrical wire that is implanted into the spinal cord. It's connected to a little generator which is also implanted. Bad idea. It's painful, it's expensive, it has a very high rate of complications, surgical complications, and it has been shown in studies that it is no more effective after 3 years. So at best, even if it does help, it will help only for most of 3 years. But the surgical complication rate is almost 50% in these cases. Again, I would stay away. Spinal cord stimulators, especially in EDS patients, is again very risky because the dura mater, which is the lining inside the spinal cord, is very thin. And once it's damaged, it's literally impossible to repair it. Hyperbaric oxygen, I haven't seen it being recommended for EDS patients. It's being recommended for nerve pain. There are absolutely no studies to show that it works. There are a few studies that have come out, mostly anecdotal reports, and if you look at them carefully, they are written by people who either sell hyperbaric chambers or own hyperbaric chambers. It's a very expensive treatment. There is no science behind it at all. So this is key in EDS, in Ehlers-Danlos syndrome, prevention. If there's one thing that you would want to take away from tonight is prevention. Because again, we know that once in EDS, we know EDS patients are more prone to tissue damage, even with minor injuries. The problem is when there is tissue damage, the wound does not heal as well. When it does heal, it's not as strong. So it's like almost leaving a permanent weak scar. So prevention is key, especially those who have children with EDS. Try to avoid getting into sports activities or any activities in where they are at risk of causing any injury to the tissue. Now, this again goes for surgical scars also. Jumping to surgeries, I would not jump to surgery easily because one of the things you have to understand, surgeries, when they do surgery on the human body, they repair tissue, they fix things, but they depend on the native tissue to repair itself a lot. The problem is in EDS is that the native tissue is not that strong, and oftentimes surgery can result in disastrous results. So these are some of the tips I quickly put in there. Preventing pain, especially for lower back pain, do not stand on one hip or sway at the hips. Some people tend to, we all do it, we may stand on one hip. Say your left knee hurts, you tend to put all your weight on the right side, and then it actually causes more harm. Try not to sway at the hips. Do not stand on the outside of your foot because if, some people do that because, if you have pain or if you're uncomfortable, you may find more stability when you stand on the outside of your feet. Avoid that. Do not sleep on your stomach. Sleeping on your stomach hyperextends the back, it hyperextends the neck, hyperextends a lot of things. I would avoid sleeping on your stomach. And especially with your head turned to one side for any prolonged period of time. It's a common cause for neck pain in patients with EDS. Most of you are familiar with this posture. Do not sit with legs outstretched or what's called a W position. This is a bad idea for these ankles, bad idea for your hips. So again, kids tend to do that a lot. Kids with EDS tend to do that a lot. I would avoid this. This is a hyperextended knee. As you can see, this is an extended knee. This is a hyperextended knee. And you can see this is going to compress on the, remember I talked to you about the pad of fat under the patella? This is going to pinch that. The ligaments that are inside the knee over here are going to get overstretched. The muscle at the back of the knee is going to get overstretched. So try to avoid hyperextension of the knee, especially in the standing position. Do not sit kneeling with the buttocks resting on the ankles. It really puts a lot of strain on the ankle joints, can cause damage to the ankle joints. So preventing pain in EDS, especially when you're working at home, avoid repetitive use of any joint, say in vacuuming. So when you're vacuuming, you're using your shoulder joints, your elbows, your wrist joints, raking leaves, repetitively filling the dishwasher. Remember, dishwasher is, well, we all have dishwashers. All our dishwashers are at a lower level, and you have to keep bending down repetitively. Stirring is again, so these are some of the repetitive activities to avoid. But again, these are activities that we have to do. You can't get away from them. So what I suggest is doing these activities for short periods of time. Say 5 minutes or 10 minutes. So vacuuming for 5-10 minutes, then go do something else. Come back after about 15 minutes. Do some more vacuuming for 5-10 minutes. Raking, same thing. Do it for some short periods of time. Pulling weeds, or anything that involves repetitive use of your joints. Avoid that. So change activity frequently. Work surface. Donna, you can't just eat out every day. Work surface, kitchen counters. Unfortunately, kitchen counters are not. They're all standard and they're not designed for patients with EDS. Raise your kitchen counter height. You can use blocks to raise your work surface area, so that you're not bending over. You're not sticking out your chin forward. You're not leaning forward. You always use something, blocks or something, to raise your work surface. Sleeping, almost all EDS patients wake up with pain and stiffness, and most of the stiffness is from the muscles. Use soft mattresses. Again, soft mattresses. If you have a significant other you're sleeping with, you may want to get separate mattresses. Memory foam pillows. I did put in feather pillows, but I'm not so sure. I think memory foam pillows. We actually talked about this in our last presentation. And if you go to the store, body support store that sponsors these webinars, there are some very nice memory foam pillows over there that you can look at. Shopping. Do not carry heavy bags hanging from your shoulder. Your friend over here is wheels. Use wheels. Shopping trolley, anything that has wheels, use that. Because if you have a heavy bag hanging on one side, you're putting uneven loads on your spine, on your hips, on your knees. Every part of your body, every joint in your body, you're putting uneven loads. Don't carry grocery bags in the hand, especially heavy ones. Put them in shopping trolleys. Handbags. I can't even tell you how important this is. Keep your handbags light. Most of us, most women who use handbags have they literally carry everything other than the kitchen sink. Clothes, keep them loose and light. Women who wear, I'm sorry, I take that back. Bra straps should be wide and preferably crossover. Something like sports bras, they should cross over so they're not pulling too much on your spine and your shoulders. I think on the body support store there is a back support that they have. It's a very decent one. It's a crossover strap that you can see. Light and soft shoes, and they should be, of course, well-balanced orthotics. Going to the dentist. EDS patients are at the dentist office a lot. We talked about it on our last presentation. Soft teeth, lots of cavities, gum recession, crowding of the teeth, and not to mention temporomandibular joint dysfunction. So EDS patients show up at the dentist a lot. The sad part is that most dentists are not aware of EDS. They don't know much about EDS. And again, it's, most of us in the medical field assume EDS is a joint problem, and that's what it is. So dentists really don't pay attention to it. Unfortunately, EDS is not just a joint problem. It's a lot more than that. So rather than just going to the dentist and saying, look, I have EDS, what I suggest is going to the dentist and sitting down with him or her and saying, look, I have Ehlers-Danlos syndrome. It's a connective tissue disorder, and and you can list the issues that are associated with dental issues and EDS, or EDS and dental issues. The main one being, of course, the numbing medicine, local anesthetics. Local anesthetics can go three ways in EDS patients. Either they don't work at all, or they are way too sensitive to them, or they work like anybody else normally. There's no way of finding out other than trying it. So let your dentist know that if you're not sensitive to numbing medicine, then any dental procedure that's painful, they have to consider using general anesthesia. Now, patients with EDS can open their mouth big and wide, and so it's great. Dentists like that, but unfortunately, it's not good for your temporomandibular joint. So they need to know that. They need to know that just because I can open my mouth wide doesn't mean that you open it that wide. They have to use, they have things that they can put, supports that they can put inside the jaw, inside the mouth to make it much more comfortable. But don't go to the extreme of mouth opening. Keep it within mid-range. Again, EDS patients have lots of issues with neck pain and headaches. The good news is that the newer models of dental chairs, they are no longer dental chairs. They can go flat, and preferably ask for a more flat position with the neck supported. This is important. So these are some of the things that you shouldn't expect your dentist to know automatically. You may want to list them and bring them to the dentist and say, look, I have this condition, and these are the things that I need to make sure that can be done and followed up with. Service dogs. Actually, I have a pair of service pictures of. This guy on the left is Watson, and the guy on the right is Usher. They both belong to patients with Ehlers-Danlos syndrome. They both belong to students who have been able to go to college because of these service dogs, because of Watson and because of Usher. Service dogs are really, really very important with patients with Ehlers-Danlos syndrome. It would be a long conversation, but service dogs can do a lot for patients with EDS. Remember, EDS comes with POTS. It comes with mast cell activation disorder, seizures. These dogs help with functioning and independence. They are a constant companion. They understand their owner's pain. They can call for help when you're in a distress. What if you have a POTS, you fall down, you break a bone, they are there, you dislocate a joint, they are there to call for help. They provide a sense of security. Like I said, these two girls, they could go to college just because they had these service dogs. Otherwise, it would be impossible for them to go to college. They provide stability while walking. Usher is a big guy, and he actually leans against her master. If she's getting unstable, he will lean against her, and if she were to fall, she falls on him and cushions her fall. They help with opening and closing doors, switching on and off lights, all kinds of things. POTS, they can actually sense when their owner is getting to be dizzy or having a seizure. In ADS patients in pain, they protect the limb from being injured or touched. Most of all, they boost confidence in their owners. So this is not a pain condition. Dysautonomia, but I'm not sure if you're going to be having somebody talk about dysautonomia. But I wanted to briefly touch on it, especially because it's important in patients with EDS in terms of pain. So dysautonomia is an umbrella condition. And under dysautonomia, there are a bunch of other conditions that come under this umbrella condition, one of them being POTS, otherwise known as postural orthostatic tachycardia syndrome. How do you know if you have POTS? If you feel dizzy or almost fainting, or if you faint often, if you feel your heart is racing, or if you have, some people might not notice their heart racing, they may notice it as an anxiety sensation. The official definition is there is an increase in their heart rate by 30 beats per minute within 10 minutes of standing, or if their standing heart rate is 120 beats per minute. There is no significant change in blood pressure. They may present with fainting, syncope or almost syncope, which is fainting. Some actually faint, and some will have almost sensations of fainting. But the critical one is increase in heart rate, which some patients sense as an anxiety attack. Patients present with brain fog. We think it's mostly because of poor blood circulation to the brain. They present with digestive problems, nausea, constipation, gastroparesis. Gastroparesis is slowing down of the intestines. Patients with gastroparesis have fullness with a small portion of food. They have distension. These patients will present with chronic fatigue or headaches. So how do you figure this condition out? There are cardiologists who specialize in dysautonomia. A good place to look for a specialist is to go to this website called Dysautonomia International. Again, it's called Dysautonomia International. I think they have an interactive map to show cardiologists and neurologists who treat dysautonomia. Some neurologists treat dysautonomia also, or POTS. It's easy to make a diagnosis. There's something called orthotics. Orthotics are you check your blood pressure and pulse rate while you're lying down. So you should be lying down for half an hour. So lie down on a bed for half an hour, check your blood pressure and your pulse rate, and then stand up. And as soon as you stand up, check your heart rate and your blood pressure again. And then you keep standing for 10 minutes, check your heart rate and blood pressure, and you'll notice if it meets this criteria, if your heart rate increases by 30 beats per minute, or if your heart rate is at 120 beats per minute, and there's no significant change in blood pressure, then you are symptomatic of POTS. Officially, they have a test called the tilt table test. It's not an exciting test. For patients with POTS, it's actually pretty tough to go through it. Briefly, what they do is they strap you to a table, and then they check your blood pressure and your heart rate. They tilt it, and then they look at your blood pressure and heart rate. If you have POTS, it's a pretty miserable test. So most physicians can do the diagnosis in the office, just you doing the orthostatics, which is checking the blood pressure and heart rate in the office itself without doing a tilt table test. The treatment for POTS is very elaborate, but I've just mentioned a few things over here. A high salt diet. Actually, the website Dysautonomia International has some recipes for a high salt diet. Some patients actually wind up on being salt pills. Increase oral fluids. Drink as much fluids as you can, especially fluids that have electrolytes in them. Some patients wind up on being on IV fluids. Compression pants. Compressions. Not stockings, but compression pants. These compression garments should go up to the waist or the thighs at the most, because it pushes up the blood. So patients with Ehlers-Danlos syndrome have low venous tone, which means that when they stand up, a lot of the blood pools into the lower half of the body, and they have a hard time pushing it back up to the heart. And that's why they have symptoms of POTS. So compression pants are very helpful in these cases. There are a bunch of drugs that can be used. I can't discuss them all over here, but some of the drugs that are commonly used are midodrine, propranolol, Adderall. So something to look at. But the easiest thing is to start with a high salt diet, increase oral fluids, get compression garments. Again, you can get them online. Zensa is a good company to try. They really make some really good compression garments. This is not a medical condition, but I just wanted to bring this up because I see this a lot. Patients with Ehlers-Danlos syndrome have a very high sympathetic overdrive. So the sympathetic nervous system is the nervous system that is activated during flight and fight. So if you're in a flight or fight situation, like you're in danger or you're being attacked, our heart rate goes up, our blood pumps faster, our pupils dilate, we start sweating, and that's because of the sympathetic nervous system. The problem is in Ehlers-Danlos syndrome, the sympathetic nervous system is constantly active. And they're in a constant state of flight or fight. They always feel like they always live on the edge. I describe it as walking along the edge of a cliff. They're always in a state of flight or fight, which often gets diagnosed, or I should say misdiagnosed, as anxiety or panic disorder or post-traumatic stress disorder or ADHD. But these are conditions that, and any of these diagnoses that patients with EDS have, I would go back and relook at them and say, is it because of my EDS that I have I have a high sympathetic drive? Poor sleep is one of the reasons. It's called non-restorative sleep, where, when normal sleep is the brain wave is at rest, there are very few blips. In patients with EDS who have high sympathetic drive, and almost all patients with Ehlers-Danlos syndrome have a very high sympathetic drive. Their brain is constantly active, firing signals constantly. It makes them very restless. So patients with EDS don't sleep well. It's not just because of pain. They just don't sleep. It's because they have a high sympathetic drive. They're in a constant state of flight and fight. It's not because they have anxiety disorder or a panic disorder or a PTSD or ADHD. The problem is that if they get diagnosed with, say, panic disorder or ADHD, for example, the treatment is actually counterproductive. So you have to be on medicines that actually bring down this sympathetic drive. This is the last condition that I want to discuss. It's called mast cell activation disorder. Some people call it mast cell activation syndrome, mast cell activation disorder, MCAD, whatever. So what is this? Mast cells are cells that are found in the blood. So normally blood has, red cells, white cells, blue cells, green cells, all kinds of cells. One of the cells is called mast cell. And the purpose of having mast cells in our blood is they contain histamine. They actually contain histamine and heparin. But histamine these mast cells contain histamine. And they're involved in allergy. So when you have an allergy reaction, these mast cells release. So, for example, if you're allergic to chocolate, and if you take chocolate, these mast cells start releasing histamine, which causes the flushing, the itching, the hives, the asthma attack, and all that. Mast cells are also involved in wound healing. Now, remember we said that Ehlers-Danlos syndrome patients have poor wound healing. Is this because they have a connective tissue disorder, or is it because of poor mast cells, or is it because of both? We don't know. That is why I call this connecting the dots. We haven't been able to connect these dots. So the mast cells are also protect us from infection, and a lot of the EDS patients are very prone to infections. So again, this is the purpose of mast cells. They live in in our body. They're normally found. They contain histamine, and they release histamine when there's a trigger. The problem is that in EDS we don't know what the trigger is. Is it because are these mast cells very sensitive, or is there a trigger that there's an unknown trigger we don't know? So the way I look at it is, if patients have unexplained flushing or unexplained itching, unexplained gastrointestinal disturbance, especially things like nausea or gastroparesis, I suspect mast cell activation disorder. They have unexplained fluctuations in blood pressure. Now again, POTS presents with fluctuations in blood pressure. So we have a mixed picture here. Patients who have, so I have a low threshold to diagnose patients with mast cell activation disorder based on if they have unexplained flushing, itching, or gastroparesis. I have a low threshold to diagnose them with mast cell activation disorder. MCAD patients will present with nausea, vomiting, stomach pains, gastroparesis, slowing of the GI tract, low blood pressure, syncope or neurosyncope. Again, this is the same as POTS. They can present with chronic fatigue, headaches. They have temperature instability. They can go from hot to cold, cold to hot within minutes. They may present with multiple chemical sensitivities. They're sensitive to multiple foods, drugs. One little point over here, sometimes you may be sensitive to a drug and it may not be the active ingredient itself. It may be the filler in the drug. For example, if you take, say, ibuprofen and then all of a sudden you become sensitive to ibuprofen, try going to a different brand. It may be the filler that's doing it. Patients with mast cell activation disorder present with dry eyes, difficulty focusing, which is a feature of EDS also, hair loss, inflammation of the bladder. They have premature osteopenia, thinning of the bone. They have migratory joint pains. That means they have joint pains, multiple joint pains, and they're often are misdiagnosed as rheumatoid arthritis or polymyalgia rheumatica. Usual analgesics like opioids and NSAIDs can actually make MCAD worse. They make these mast cells trigger and release histamine. It's very difficult to diagnose this. The mast cell count is usually normal. They're not increased. It's very difficult to find a specific trigger that causes these mast cells to release histamine. It does cause brain fog and sleep apnea for some reason. The diagnosis is made on clinical examination. It's purely based on talking to the patient if they have unexplained highs, rashes, or if they have a lot of these symptoms of MCAD. Testing is not very helpful. There are a bunch of tests that can be done. Tryptase levels, they can check for TASE levels. Again, tryptase levels can be normal in patients with MCAD. Some physicians do suggest doing the tryptase level when they are having a flare-up of their mast cell activation disorder, which is kind of hard to do. Bone marrow biopsy, urine tryptase levels can be done, but again, if they're negative, that doesn't mean anything. Treatment is to try antihistamine blockers. Most cold remedies, Benadryl, Zyrtec, Claritin, all of these are antihistamine blockers. Combined with ranitidine or famotidine, which is Zantac or one of those. Other drugs to try is cromolyn. Cromolyn is a mast cell stabilizer. It stabilizes the mast cells. So it prevents them from releasing histamine. Another drug that you can use is called ketotifen. And that brings me to the end of the presentation.
Well, thank you, Dr. Chopra. That was very thorough and a lot of good information, particularly related to drugs, and that was one of the areas that we've had a number of questions. And I'm wondering how much time you'd like to spend on Q&A. I see you have 27 questions up there. Would you like to proceed with those? And you may not make it through all of them, but I'd like to put a time on it if we could, and let's see how we do with it. So I'll let you take it from here.
So any suggestions on how to get a posterior sublux ribs back in place? This is one of the tough ones. It's really very difficult. Getting it back in place is not the problem. Keeping it in place is the hard part. And in the last presentation, we had talked about trying one of those cross straps. They're actually, you can get it on the body support store. It's a cross strap that you can use for your upper back that kind of keeps the back in place, which will keep the ribs in place. But it's a really difficult one. The other one is to just, it's hard, but keep your muscles, the key thing is to the muscles strong. That's the main thing. If you keep your muscles strong, the bones tend not to subluxate as much. Do you know anything about outcomes with body work modalities that address connective tissue specifically? I've begun a self-help program called MELT that uses a soft foam roller. No, Susan, I don't know. I am not aware of this. Sorry. Epiphyseal dysplasia, is this common in ADS? They're ordering a skeletal survey on me because the X-ray of my knee shows double-layered patella. I'm still uncertain what this means for care. Bones are made up of our connective tissue, and they literally any bone, starting from having soft teeth, osteopenia. So having a bone abnormality is not surprising in Ehlers-Danlos syndrome. But if you already have a diagnosis of Ehlers-Danlos syndrome, if it shows up, if a bone abnormality shows up on an X-ray or MRI, treat it only if it's bothering you. Treat it only if it's doing any harm. Don't treat it just because it's there. Which I often tell my students is, don't treat the X-ray, don't treat the MRI. Treat the patient for their symptoms. Thank you for taking the time to do this. I'm wondering whether you have found medical marijuana or the pharma derivatives helpful. If so, in what way have you found it to help? I personally, not just me, a lot of us think that medical marijuana works very well for Ehlers-Danlos syndrome. I didn't put it in my presentation because we have an international audience here. I don't know, in some countries, it's whether it's legal, not legal, and in a lot of the states in the United States, they're not yet legal. But all in all, in states or in countries where it's legal, medical marijuana actually works really well for Ehlers-Danlos syndrome. Given a choice between taking an opioid versus taking a medical marijuana, I would be more inclined to do the marijuana than opioids. The beauty of medical marijuana, which we're just kind of discovering this, is that it works very well topically also as an ointment or as a cream on certain joints. It works really well. You can actually have the pharmacy where you get it. They can actually compound it into a cream or as an oil that can apply over the joint. So that's one of the things that we've just recently discovered, that the pharmacological pills in the United States, we have a drug which I'm blanking out right now. It's not very useful. It's not the same thing. I think the pure compound is much better to use. So, long story, I think medical marijuana is a great way to go in cases of Ehlers-Danlos syndrome pain. I was wondering whether you have found what do you mean by raising the heels in foot exercises? What about arch support during barefoot time, and how much barefoot walking per day? I don't know how much barefoot walking per day is good. I didn't find that recommendation anywhere. The reason why bare feet is recommended is because, remember I talked about joint sense, how we need to train our body to get back that joint sense. And so when you walk bare feet, you're actually sending back signals to the brain about the position of your feet through the skin. That helps with proprioception. Raising the heel means that you can raise your heels two ways. One is you can go tiptoe or you can lean forward. The recommendation is to go tiptoe rather than leaning forward. So raising the heel is much better because you exercise your muscles and the joints much better by going on tiptoes rather than leaning forward. Are EDS patients prone to Baker's cyst? Not sure. I haven't come across anything like that. But I wouldn't be surprised because, again, Baker's cyst is a very common finding in general. Again, it's connective tissue, and it's quite common in the general population. So I wouldn't be surprised it's much more common in EDS. What is the difference between compression knee sleeve and a hinged knee brace? Big difference. Compression. So why was I recommending compression knee sleeve? The thing is that compression knee sleeve, what it does is it helps with proprioception. So when you're wearing a sleeve, a compression sleeve around your around the joint, say for example around the knee, then the brain uses signals from the sleeve touching the skin to give it an idea as to whether you're hyperextending the knee or not. If you use a hinged knee brace, then you can't train it'll protect you, but you can't train your brain to prevent it from hyperextending. It'll only help you when you're wearing the hinged knee brace. Does hyperextension of the knees cause pain towards the inner part of the leg near the knee? Does hyperextension of the knee cause pain towards the inner part of the leg near the knee? Yes, it does. Exactly. It pulls. So the question is, I lost the question. Does hyperextension of the knees cause pain towards the inner part of the leg near the knee? It does, because hyperextension causes a strain of the ligaments, it causes a strain of the muscles around the knee, and it does cause pain in those muscles. IT band, yes, most patients who have pain from their knee joints have a tight IT band. Foam rollers, physical therapists can do a great job of loosening up the tight IT band. Several years ago, my toes started to curl into a clawing position. I saw an orthopedist who did not have any thoughts about how to stop this. Eventually, I have developed hammer toes of the PIP joint. They're painful on the tops, even though I generally only wear sneakers. You know, this is hard to say. I mean, clawing of the toes in EDS, I haven't seen any connection between them. It could be that the only thing I can think of it is that it's affecting one of the nerves that's causing the toes to go into a clawed position, but it's not a direct effect of the Ehlers-Danlos syndrome. I don't really have a great suggestion for treatment of claw toes. The only thing to do would be to, talk to an orthopedic surgeon or a podiatrist and go in there and actually loosen up some of the contractures. I use a foam roller to put the discs in my upper and lower back in multiple times every day. Is there a back brace I can wear even for a short time during the day to keep the discs from subluxating? They come out when I sit up in a chair as I hunch forward uncontrollably. It's a tough one because the problem with spine in Ehlers-Danlos is because the spine has a ton of joints, and like joints everywhere, they tend to subluxate a lot. Prevention is a key. So one of them is what is called as core strengthening exercises, where you want to keep your core muscles strengthened. The core muscles are the muscles that pad the spine. That is one key way to do it. The other one is prevention. Again, be very cognizant about your posture. One of the braces we had talked about last time was to use one of those cross straps for the upper back. CRPS, skin changes, lesions. What kind of lesions? Nodules, perhaps? No, the skin lesions in CRPS can be anywhere from a pinhead size to full-blown bubble-like lesions. They're called bulla, and they're not really nodules, but they're little. They're a break in the skin actually. That we see them in patients with CRPS. Can you speak to the long-term cognitive impairment and other concerns regarding side effects about gabapentin? Gabapentin is an old drug. It's been around for a long time, and we haven't seen any reports of long-term cognitive impairment. Most of them are very short-term. We haven't seen or heard of any long-term side effects from taking gabapentin. Remember, gabapentin was designed for children actually, and I believe it's been around for well over 15 to 20 years, and we haven't seen any long-term side effects from them. Do you feel that topical compounded prescription pain creams help? We talked about that. Yes, topical compounded prescription pain creams do help, but be careful. It's not just simple as having an active ingredient. You also have to make sure that the inactive ingredient or the compound that is mixed helps the drug penetrate through also. That's more important. On the naltrexone, you said no tramadol. What about Toradol injections? Yes, you can have Toradol, absolutely. Magnesium, isn't it important to keep the calcium and magnesium in correct balance? Yes, you're right. I didn't talk about vitamin D and calcium, but those are in addition to everything else. You have to make sure your calcium and your vitamin D are also up to level. Those you can check blood levels. Magnesium, the problem is that you can't check blood levels. So it's really important to have, so I always suggest having magnesium as a supplement. Have you found alternative treatments such as healing touch, Reiki, acupuncture to be effective? Yes and no. It all depends on, number one, who's the practitioner. These are acupuncture, for example. They're not regulated. They don't have a standardized testing. So it depends on the training, the experience of the person who's doing the acupuncture. It also depends a lot on what they're treating. And as a rule of thumb, my theory on this is try it. Try anything as long as there's no harm in trying it. It may help, it may not help. As long as it doesn't harm you, you can try it. Healing touch, Reiki, acupuncture. I've known patients where it has helped, and it's worth a try. What is the risk of nerve blocks or ADS? Nerve blocks, again, nerve blocks, if you're treating nerve pain, we haven't, it can actually, it doesn't really help nerve pain, nerve blocks. If you have joint pain, for example, say a back pain, where they're treating your back or disc pain, a lot of the most patients with Ehlers-Danlos, the pain is mechanical, it's not inflammatory. So what happens is that, one, you're putting in a needle that's damaging tissue. When it damages tissue, it makes the pain worse, and that tissue doesn't heal well. The second thing is, you're injecting cortisone. Cortisone doesn't help with mechanical pain. It only helps if you have inflammatory pain. For example, if you have arthritis, yes, it'll help. I do recommend doing injections in EDS patients, but I recommend it very cautiously. not to be very careful about it. It can make the pain worse. Would you prefer a patient staying on fentanyl patch long-term or try nerve ablation to help with rib pain from 12 spontaneous rib fractures? Rib fractures are very painful, and if you have 12 spontaneous rib fractures, I think you're better off staying on the fentanyl patch for the pain. I don't think nerve ablation is going to help that. Are radiofrequency ablations considered nerve blocks? Since you brought up nerve blocks, they are considered a kind of nerve block, but radiofrequency ablation may be an option to try if they're in some cases, but not. Again, do it very cautiously. Ice, heat, alternative for chronic pain like IT band, bursitis. There's no rule of thumb. You can try either one of them, heat or ice. Generally, I think heat works well for muscle pain. Ice is more for joint pain, but try either one of them, and whichever works for you is the best way to go with it. What would be the benefit of small fiber neuropathy skin biopsy in light of negative nerve conduction study? Nerve conduction studies do not detect small fiber neuropathy. The only way you can diagnose small fiber neuropathy is by doing a skin biopsy. That's the problem. Skin biopsies are more like a bad needle puncture. They're not that tissue damaging, so if they suspect small fiber neuropathy, then the only way to diagnose that would be to do a skin biopsy. There's another study that they can do. It's called a QSAT, which they look at the sweat test. They can do that. Do you have an opinion on the use of Butrans patch? Butrans is a patch for pain. It's a narcotic. It contains a drug called buprenorphine. It's the equivalent of Vicodin. It's a fairly decent patch for pain. It's worth a try again. The only reason you would want to try it is that if you've already tried some short-acting opioid pills that have helped you, then you might like to try the Butrans patch. But it's a pretty decent patch to try. Do you recommend using a sleep number bed for which you can adjust? I don't know much about the sleep number bed. I don't have any knowledge of that. Do you have any knowledge of specific organizations that have previously provided service dogs to people with EDS? Yes, actually I do. There is an organization called NEADS, N-E-A-D-S. N-E-A-D-S. There are a bunch of organizations actually. It doesn't matter whether it's EDS or whatever the condition is. They don't train service dogs according to the medical condition. They train service dogs according to your need. For example, a patient with Ehlers-Danlos syndrome may not have POTS, but may have CRPS pain. So they would train the dog for that. If there's a patient with EDS who has more POTS symptoms, then they would train the dog more for the POTS symptoms. So it's not according to the medical condition, but according to what the person needs. It's a great way to, it's a good idea to call them and talk to them. Most of them are voluntary organizations. I have put on a quercetin for MCAD. I don't know what quercetin is. I'm sorry. It sounds familiar, but I really don't know much about that. Will barefoot walking with socks on still help proprioception? Yes, it will. Yes, it will do that. Do you know if it is advisable to use a dry needle treatment for the pain? We actually talked about it in my part 1. It's definitely worth trying it. It's not a bad idea. dry needling for muscle pain. Would you explain fibromyalgia syndrome? Is it common in EDS? I think fibromyalgia is a different condition from EDS, and oftentimes patients with Ehlers-Danlos are diagnosed as having fibromyalgia just because they were missed while being diagnosed for EDS. The symptoms of fibromyalgia are a lot similar to Ehlers-Danlos syndrome, and so I wouldn't worry too much about it. I would, if I was diagnosed with both EDS and fibromyalgia, I would just treat it as EDS because the treatments are pretty much the same. How does a stimulant like Adderall help in POTS patients? That's a long answer over here, but what it does is it helps with the way it does it is helps increase sympathetic overactivity, which helps with bringing up the blood pressure, which helps bringing down the heart rate. It's a very long explanation to go into that for now. And I think that brings us to the last of my questions.
Yeah, fabulous, Dr. Chopra. We appreciate you going through all of the questions and spending a little extra time with us. It's really incredible.
Thank you, Dr. Chopra. It was an excellent and informative presentation, and as always, your compassion for EDS patients just really shines through. And thank you for being so giving of your time and your knowledge for us and all of your contributions to the EDS community.
Thank you, John and Deanna, for having this. And for those of you, most of you don't know this, but John spends a lot of his time and his personal resources for holding this webinar, and I feel that's a very noble cause, John, for you to do this, and I really applaud it, and I do try to use the store, the body support store, as much as possible to help fund these webinars, and I think it's very noble of you both to make it free for patients. That's just so noble of you guys to do that. So I again thank you from the bottom of my heart.
Well, we certainly appreciate that, and thank you for your contributions. And I understand you will be giving another presentation, and we'll get that scheduled and get that on the books in the near future. And our next presentation will be on May 7th, and you will see a posting on our site for that presentation by Dr. Stacy Patella. And the recording for tonight's presentation will be on our site. Give me a couple days to get that set up, and you'll also get an announcement to that effect. So we ran over a little bit tonight, but I think it was well worth the extra time. And I'd like to thank you all for sticking with us, and have a fantastic evening, and looking forward to having you join us next time. Good night.
See you next time. Good night.
Thank you.